Good day everyone. So in this video, we are going to report about drug used to treat gastroesophageal reflux and peptic ulcer disease. So the objective of this is first, cite common stomach disorder that require a drug therapy. Second, identify factors that prevent breakdown of the body's normal defense barriers resulting in ulcer formation. 3. State the drug classification and action used to treat stomach disorder. 4. Develop health teaching for an individual with stomach disorders that incorporates pharmacologic and non-pharmacologic treatment.
Physiology of the stomach. As a major part of the gastrointestinal tract, the stomach has three primary functions: storage of food until it can be used in a lower GI tract, mixing of food with gastric secretion until it is partially digested, semi-solid mixture known as skim, and slow emptying of the stomach at a rate that allows proper digestion and absorption of nutrients and medicine from the small intestine. Three types of secretory cells line portion of the stomach: Schwann cells, parietal cells, and mucous cells. The Schwann cells secrete pepsinogen, an inactive enzyme. The parietal cells are stimulated by acetylcholine from cholinergic nerve fibers, gastrin, and histamine to secrete hydrochloric acid. Hydrochloric acid activate pepsinogen to pepsin and provide the optimal pH of pepsin to start protein digestion. Normal pH in the stomach ranges from 2 to 5, depending on the presence of food and medication. Hydrochloric acid also breaks down muscle fiber and connective tissue ingested as food and kills bacteria that enter the digestive tract through the mouth. The parietal cells also secrete intrinsic factor needed for absorption of vitamin B12. The mucous cells secrete a mucus that coats the stomach wall. That 1 mm thick mucus coat as alkaline and protects the stomach wall from damage by hydrochloric acid and the digestive enzyme pepsin. It also contributes lubrication for food transport. Small amounts of other enzymes are also secreted in the stomach. Lepacy starts the digestion of fats, and gastric amylase digests carbohydrates. Other digestive enzymes are also carried into the stomach from swallowed saliva. Prostaglandin also play a major role in protecting the stomach walls from injury by stomach acid and enzymes. The prostaglandin are produced by cells lining the stomach and prevent injury by inhibiting gastric acid secretion, maintaining blood flow, and stimulating mucus and bicarbonate production.
The common stomach disorders: gastroesophageal reflux disease, or GERD, more commonly referred to as heartburn, acid indigestion, or sour stomach, is a common stomach disorder. Approximately 1/3 of the United States population experiences heartburn each month, and 5 to 7% have heartburn daily. Common symptoms are burning sensation, bloating, belching, and regurgitation. Other symptoms that are reported less frequently are nausea, a lump in the throat, hiccups, and chest pain. GERD is the reflux of gastric secretions, primarily pepsin and hydrochloric acid, up into the esophagus. Causes of GERD are a weakened lower esophageal sphincter, delayed gastric emptying, hiatal hernia, obesity, overeating, tight-fitting clothing, and increased acid secretion. Acid secretions are increased by smoking, alcohol, carbonated beverages, coffee, and spicy foods. Most cases of GERD pass quickly with only mild discomfort, but frequent or prolonged bouts of acid reflux cause inflammation, tissue erosion, and ulcerations in the lower esophagus. Any person who has recurrent or continuous symptoms of reflux, especially if the symptoms interfered with activities, should be referred to a physician. These symptoms may also accompany more serious conditions such as ischemic heart disease, scleroderma, and gastric malignancy. Peptic ulcer disease or PUD. PUD is actually several stomach disorders that result from an imbalance between acidic stomach contents and the body's normal defense barriers, causing ulcerations in the GI tract. The most common illnesses are gastric and duodenal ulcers. It is estimated that approximately 10% of all people in the United States will develop an ulcer sometime in their lives. The incidence in men and women is approximately the same. Race, economic status, and psychological stress do not correlate with frequency of ulcer disease. Often, the only symptom that is reported is epigastric pain described as burning, gnawing, or aching. Patients often report that varying degrees of pain were present for a few weeks and were then gone, only to reoccur a few weeks later. The pain is most often noted when the stomach is empty, such as at night or between meals, and is relieved by food or antacids. Other symptoms that cause patients to seek medical attention are bloating, nausea, vomiting, and anorexia. The formation of ulcers appears to be caused by a combination of the presence of acid and a breakdown in the body's defense mechanisms that protect the stomach wall. Proposed mechanisms are oversecretions of hydraulic acid by excessive numbers of parietal cells, injury in the mucosal barrier, such as that resulting from prostaglandin inhibitors, including aspirin, and infection of the mucosal wall by Helicobacter pylori. It had been thought that no bacterium could survive in the highly acidic environment of the stomach. However, Helicobacter pylori was first isolated from patients with gastritis in 1983. It appears that the bacterium is able to live below mucous barrier where it is protected from stomach acid and pepsin. Helicobacter pylori is now thought to be associated with as many as 90% of duodenal ulcers and 70% of gastric ulcers. The exact mechanism by which Helicobacter pylori contributes to ulcer formation is not known, but several hypotheses are being tested.
Several risk factors increase the likelihood of peptic ulcer disease. Number 1 is there appears to be genetic predisposition to PUD. Some families have a much greater history of PUD than others. It is commonly held belief that stress causes ulcers, but no well-controlled studies have supported this. Cigarette smoking increases acid secretions, altered blood flow in the stomach wall, and retards prostaglandin synthesis needed for defense mechanism.
Treatment of gastroesophageal reflux and peptic ulcer disease. The goals of treatment of GERD are to relieve symptoms, decrease the frequency and duration of reflux, heal tissue injury, and prevent recurrence. The most important treatment is a change in lifestyle, weight loss, reduction or avoidance of foods and beverages that increases acid production, reduction or cessation of smoking, avoidance of alcohol, and consumption of smaller meals. Additional therapy includes remaining upright for 2 hours after meals, not eating before bedtime, and avoiding tight clothing over the abdominal area. Hallucinogens may be used to increase saliva production, and antacids and allergenic acid therapy may be used to provide relief in patients who experience infrequent heartburn. If the patient's symptoms do not improve within 2 to 3 weeks, or if the patient's condition is severe, additional pharmacologic measures should be tried to reduce irritation. About 5 to 10% of patients with GERD require surgery. The treatment of PUD and GERD is somewhat similar, relieves the symptoms, promote healing, and prevent recurrence. Lifestyle changes that eliminate risk factors such as cigarette smoking and foods that increase acid secretion should be initiated. Patients rarely need to be secreted to a bland diet. If NSAIDs are being taken, consideration should be given to switching to acetaminophen if feasible. For decades, the treatment of ulcers focused on reducing acid secretions, neutralizing acids, or coating ulcers greater to hasten healing. Major changes in therapy have come about because the US FDA has approved the use of antibiotics to eradicate Helicobacter pylori. Several large studies are currently underway to both refine the healing and reduce the recurrence rate of ulcers. Various combinations of antibiotics, bismuth, and anti-secretory agents are being used to eradicate Helicobacter pylori.
Drug therapy for gastroesophageal reflux and peptic ulcer disease. Actions: antacids neutralize gastric acid, thereby causing the gastric contents to be less acidic. Coating agents provide a protective covering over the ulcer crater. H2 antagonists decrease the volume of hydrochloric acid produced, increasing the gastric pH, thereby resulting in a decreased irritation to the gastric mucosa. Gastric acid pump inhibitors block the formation of hydrochloric acid, reducing irritation of the gastric mucosa. Prokinetic agents increase the lower esophageal sphincter, muscle pressure, and peristalsis, hastening emptying of the stomach to reduce reflux. Antispasmodic agents reduce the secretion of the saliva by the chloric acid, pepsin, bile, and other enzymatic fluids necessary for digestion and decrease GI motility of secretions. Uses: antacids decrease hyperacidity associated with PUD, GERD, gastritis, and hiatal hernia. Coating agents provide a protective barrier for the mucosal lining where hydrochloric acid may come into contact with inflamed, eroded areas. They are used to treat existing ulcer craters on the gastric mucosa. H2 antagonists are used in the treatment of acute gastric acid and duodenal ulcers and gastroesophageal disease, and also for maintenance to prevent recurrence of ulcer. Gastric acid pump inhibitors are used to treat hyperacidity conditions. Prokinetic agents are used to treat GERD. Antispasmodic agents decrease gastric secretions by inhibiting vagal stimulation. They are used in the treatment of GI disorders requiring decreased gastric motility or decreased gastric secretions. Nursing process for agents used for stomach disorders. Assessment. Nutritional assessment. Obtain patient data about current height, weight, and any recent weight gain or loss. Identify the normal pattern of eating, including snacking habits. Use the food pyramid as a guide when asking questions to identify the usual foods eaten by the individual. Esophagus, stomach. Ask patient to describe any symptoms in their own words. Question in detail what is meant by the terms indigestion, heartburn, upset stomach, nausea, and belching. Pain, discomfort. Ask the patient to describe the onset, duration, location, and characteristic of pain or discomfort. Determine whether there is a relationship between the ingestion of certain types of food or drinks and onset of pain. Ask especially about the intake of coffee, tea, colas, chocolate, and alcohol. What has the patient done in the past and relieved the pain or discomfort? Have there been any changes in taste? Activity exercise. Ask specifically what type of work or activities the individual performs that may increase intra-abdominal pressure. Example, lifting heavy objects, bending over frequently. Medication history. What self-medications have been tried? What prescribed medications are being taken? What is the schedule of medication administration? Example, how frequently and when are antacids taken? Anxiety or stress level. Ask the patient to describe his or her lifestyle. What does the patient think are the stressors and how often do they occur? Chapter 30: Drugs used to treat gastroesophageal reflux and peptic ulcer disease. Smoking. What is the frequency of smoking? Nursing diagnosis. Comfort altered. Nutrition altered. High risk for less than body requirements. Knowledge deficit related to medications and lifestyle changes. Planning. Planning should be based on the assessment data, and interventions should be individualized to address patient needs. Routine orders. Most physicians order antacids 1 hour before meals, 2 to 3 hours after meals, and at bedtime. As needed, PRN medication dosages also must be discussed. Each type of medication used to treat GERD or PUD may require somewhat different scheduling to avoid drug interactions. When developing the time frames for administration of medications on the Medication Administration Record or the MAR, schedule the other prescribed drugs 1 hour before or 2 hours after antacids are given. Changes in diet require careful planning with the patient as well as the person responsible for purchasing and cooking the meals. Schedule teaching session appropriately. Not only may some foods need to be altered, but also the number of meals per day and may need to be increased with a smaller serving at each meal. Plan with the patient and family for needed changes at home, such as elevation of the head of the bed on 6 to 12-inch blocks or the use of a foam wedge for sleeping. Lifestyle changes must be introduced and planning for implementation must be mutually agreed to. Smoking cessation of reduction, work-related changes to decrease intra-abdominal pressure, measures to decrease stress. Schedule laboratory studies as ordered to detect possible GI bleeding. Implementation. Patient education and health promotion. Nutrition. Implement prescribed dietary changes. Eat small, more frequently meals to support optimal energy requirements and healing. Avoid overdistension of the stomach. Avoid milk and seasonings that are intolerable or that aggravate the condition. And avoid coffee, teas, colas, alcoholic beverages including beer, and citrus juices which may produce discomfort in persons with GERD. Avoid late night snacks or meals that could result in increased gastric secretions. Observe for foods that aggravate the condition and eliminate this from diet. Pain, discomfort. Keep a written record of the onset, duration, location, and precipitating factors for any pain experience. Medications. Take prescribed medication at recommended times to promote optimal healing. See individual drug monographs for suggested scheduling. Avoid NSAIDs and aspirin-containing medicines that irritate the gastric mucosa. Consult the physician or pharmacist regarding scheduling of this continuation of this medication. Lifestyle changes. Discuss stress and its effects on the person and implement needed lifestyle changes that are feasible. Encourage a significant reduction or cessation of smoking. Implement plans to gain sufficient rest. Fostering health maintenance. Discuss medication information and how it will benefit the course of treatment to produce an optimal response. Medications used in the treatment of hyperacidity are important measures to alleviate the irritating effects on the mucosal tissue. Stress the importance of not discontinuing treatment and the need for continued medical follow-up. Seek cooperation and understanding of the following points so that medication compliance is increased. Name of medication, dosage, route, and times of administration, side effects to expect, side effects to report. Enlist the patient's aid in developing and maintaining a written record of monitoring parameters. Example, list of foods causing problems, degree of pain relief, response to prescribed therapies. For discussion with the physician, instruct the patient to bring the written record to the follow-up visits. Drug class, antacid. Actions: Antacids lower the acidity of gastric secretions by buffering the hydrochloric acid. Normally, pH is 1 or 2 to a lower hydrogen ion concentration. Buffering hydrochloric acid to a pH of 3 or 4 is highly desired because the proteolytic action of pepsin is reduced in the gastric juice loses its corrosive effect. Uses: Antacid products account for one of the largest sales volumes, more than 1 billion annually, of medication that may be purchased without prescription. Antacids are commonly used for treatment of heartburn, excessive eating and drinking, and PUD. However, nurses and patients must be aware that not all antacids are alike. They should be used judiciously, but particularly by certain types of patients. Example, those with heart failure, hypertension, or renal failure. Long-term self-treatment with antacids may also mask symptoms of serious underlying diseases such as a bleeding ulcer. The most effective antacids available are combinations of aluminum hydroxide, magnesium oxide or hydroxide, magnesium trisilicate, and calcium carbonate. All act by neutralizing gastric acid. Combinations of these ingredients must be used because any compound used alone in therapeutic quantities may also produce severe systemic side effects. Other ingredients found in antacid combination products include simethicone, alginic acid, and bismuth. Simethicone is a defoaming agent that breaks up gas bubbles in the stomach, reducing stomach distension and heartburn. It is effective in patients who have overeaten or who have heartburn, but it is not effective in the treatment of PUD. Alginic acid produces a high viscous solution of sodium alginate that floats on top on the gastric contents. It may be effective only in the patient being treated for GERD or hiatal hernia and should not use in the patient with acute gastritis or PUD. Bismuth compounds have little acid neutralizing capacity and are therefore poor antacids. The following principles should be considered when antacid therapy is being planned. For indigestion, antacids should not be administered for more than 2 weeks. If after this time the patient is still experiencing discomfort, a physician should be contacted. Patients with edema, heart failure, hypertension, renal failure, pregnancy, or salt-restricted diet should use low-sodium antacids such as Riopan, Maalox, and Mylanta. Therapy should continue only on the recommendation of a physician. Antacid tablets should be used only for the patient with occasional indigestion or heartburn. Tablets do not contain enough antacid to be effective in treating PUD. Drug class: histamine H2 receptor antagonist. Actions: one of the primary mechanisms of hydrochloric acid secretions is stimulation of H2 receptors of the parietal cells of the stomach by histamine. The H2 antagonists act by blocking histamine H2 receptors, resulting in a decrease in the volume of acid secreted. The pH of the stomach contents rises as a result of a reduction in acid. Uses: the H2 antagonists cimetidine, ranitidine, nizatidine, famotidine are now being used to treat GERD, duodenal ulcers, and pathologic hypersecretory conditions such as Zollinger-Ellison syndrome. And for the prevention and treatment of stress ulcer is critically ill patients. Unapproved uses include preventions of aspiration pneumonitis, acute upper GI bleeding, and hyperparathyroidism. Famotidine is similar in action and use to cimetidine but has the apparent advantages of one dose daily, fewer drug interactions, and no anti-androgenic effect, which causes gynecomastia. Ranitidine is similar in action and use to cimetidine but has the apparent advantages of twice daily dosing, fewer drug interactions, and no anti-androgenic effect. Nizatidine is contrast to the other agents. It's not available in a parenteral dosage form. Therapeutic outcomes. The primary therapeutic outcomes expected from H2 antagonist therapy are relief of discomfort, reduced frequency of heartburn, and healing of irritated issues.
Drug class: gastric acid pump inhibitors, brand name omeprazole. Actions: omeprazole is the first of a class of drugs that inhibit gastric secretion by inhibiting the gastric acid pump of the parental threads of the stomach. Omeprazole has no anticholinergic or H2 receptor antagonist actions. Uses: omeprazole is used to treat severe esophagitis, GERD, gastric and duodenal ulcers, and hypersecretory disorders such as Zollinger-Ellison syndrome. Chapter Review: Gastroesophageal reflux disease and peptic ulcer disease continue to be common illnesses that are initially self-treated. The nurse should solicit information about whether symptoms have decreased and whether the patient is experiencing adverse effect from therapy. The nurse is also an ideal health professional to assess and make recommendations regarding lifestyle changes that are necessary to prevent recurrence of symptoms. If symptoms have not begun diminish over 2 weeks, the nurse should be encouraged the persons to seek medical attentions.